So, as I mentioned, we have studies for some of these drugs as monotherapy, meaning you only need the biologic, you don't need a background agent. In some patients, the combination is more effective. Even though the data says it should work as monotherapy, the combination may be better for that individual. And that's sort of something that you have to figure out. There's no data set that's going to tell you that that person can or cannot do without that. When we look at apremilast and tofacitinib, two currently approved with others in clinical trials in development for this in the JAK inhibitor class, we also see that there are agents there that can be used as monotherapy. And, I always say if she won't, or he won't, or he can't or she can't take background agents, then find a drug that's going to work well for them by itself. And so this idea that, for instance, in rheumatoid arthritis, we talk about this a lot, but in psoriatic arthritis, it becomes critical, especially since we tend to be dealing with a slightly younger population. And we have young women who may be thinking of continuing or starting families. And so many of those oral agents, we have to think through them very carefully. But the data is there to help guide us that says, yes, I can use etanercept, or I can use secukinumab, or I can use ixekizumab. I can use these agents without any background methotrexate and have a very good response. So we always say, or I always say, never double biologic. And why? Because the data says when you do that, the likelihood of increased adverse events is just enhanced. The most common thing being higher infections, with very little in the way of increased efficacy. We just don't have a cocktail combination that's going to work and be safe as well as be effective. When we talk about combination therapy, we're often talking about an oral agent, conventional synthetic DMARD combined with a biologic, but not combining two biologics together, even if their MOA is different. Now, there's some interesting molecules that are being investigated that might have two different MOAs on the same molecule. That's a different story because you're going to study safety and efficacy of that combined sort of bimodal pathway. But for me to take drug 1 and drug 2 and put them together, and they're both biologics, I'm probably going to run into trouble with just more adverse events and serious infections. There are times when we have to combine agents simply because they work better. And the most common background agent would be methotrexate, whether that's a sub-Q methotrexate injection or oral methotrexate tablets. And again, there is data that says in some patients, the more recalcitrant the patient, the more advanced their disease, the heavier or the greater the burden of disease that they have, they may need combination therapy. I mean, I always say, what's the goal? The goal is to get you well. The goal is to have you functioning. The goal is to have you get up in the morning and go and not have to think, oh my gosh, I need 45 minutes just to move my hip. That's not the goal. And sometimes that goal has to be met by adding on additional therapies. And so sometimes to do that, we have to have backbone methotrexate. Not all the time, but sometimes for sure. Well, this again is another big controversy in rheumatology. We say if one mechanism of action is not working, switch to another. And we, then get into the discussion of, are you a primary non-responder or a secondary non-responder? Meaning that it worked really well and then stopped, and then the same class can work really well again, versus the person who takes that first thing and there's zilch. Absolutely no response. And so we like to switch when you see somebody who's just not responding to that pathway. And sometimes it's just, we don't know what biologic pathway is driving an individual's disease. We don't have a really simple way of figuring that out right now. Certainly in research, there are lots of ways that we can stratify things, but with a patient, it's really trial and error. So if I see that, I've tried a TNF and it fails, maybe I'll try a second TNF and if that fails, I should not be on to the 5th TNF because we have other choices, other classes, and a different pathway may work.